which is now. Thank you, Carrie. Welcome to what is looking to be the last public hearing session for this session of the work of the Committee on Health and Human Services. We'll be hearing 3 bills in testimony this morning, starting with LD 717. Then we'll go to 718. I'm sorry, 1717, 1718, and then 1722, as I think has been published. We'll hear from the folks in favor, the folks against, and then those who are neither for nor against for each of the bills. I think we'll take a caucus break at that time, a short one after we're done with the public hearings, and then reconvene to discuss at least one bill for further consideration, LD 296 in a work session. We may be adding one of these 3 bills that we'll be hearing this morning to that list or not, depending on how things go. So let's go ahead and introduce ourselves around the circle, starting with Representative Lemlin.
Good morning, everyone. My name is Michael Lemlin. I represent House District 88, Chelsea, Jefferson, Whitefield, and part of Nobleboro.
Representative Stover.
Good morning. My name is Holly Stover. I represent House District 89, including the towns of Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
Representative Connor.
Thank you, Mr. Chair. Good, happy Friday morning to everyone. My name is John Connor. I represent House District 58, which is part of Lewiston.
Representative Craven.
Thank you, Mr. Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of.
Representative Madigan.
Good morning. I'm Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Representative Griffin.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glumber, Levant, and Cadesque.
Senator Moore.
Good morning. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Thank you, Mr. Chair. Good morning. I'm Representative Michelle Meyer, serving Southern Maine's House District 2, which is all of Elliott, where I live, and parts of South Berwick and Kittery.
And good morning to you all. I'm Ned Claxton. I represent Senate District 20, which consists of Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. If you're only listening but would like to see us live, we have a YouTube channel that you can find by going to legislature.maine.gov, looking up under committees, finding Health and Human Service, and then on the upper right-hand corner, there is an active link to our YouTube channel. So you can see prior recordings, and we'll be recording today's session also. We're ably supported by the team that we get to work with, and I'll start with Erin Dooling.
Good morning. My name is Erin Dooling. I'm one of the legislative analysts with the Office of Policy and Legal Analysis.
Anna Broom.
Hi, I'm Anna Broom. I'm the other legislative analyst for this committee, and I also work in the Office of Policy and Legal Analysis.
And Carrie Withy.
Good morning. My name is Carrie Withy. I'm the clerk for the Health and Human Services Committee. If you need any assistance this morning, you can email me at hhs@legislature.maine.gov.
These 3 folks who just introduced themselves are the glue for the committee and help us get our work done and are truly invaluable. We've also been joined by Representative Perry. Good morning.
Good morning. Would you like me to introduce myself?
If you would.
I'm Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Barron, Calais, Charlotte, Robbinston, Perry, Pembroke, and Pleasant Point.
Very good. And we're all dressed up and no place to go. Our first presenter had asked to go first. Yes, Representative Connor.
Thank you, Mr. Chair. I've been texting with the bill sponsor, and the bill sponsor has emailed me the written testimony and has asked me to read it. She is unfortunately still going through screening, I believe, at the airport. She's going to try to pop on, but she asked me to start it and read it if I could, if you would
We
allow.
talked last night about getting her first because she was in between things and wouldn't be available after 9:30. So if you'd be willing to do that, Representative Connor, we can proceed. Thank you.
Absolutely. Thank you. So keep in mind, this is from the sponsor, not me. Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. I am Representative Kathleen Dillingham. I serve as the Republican leader in the Maine House of Representatives, and I proudly represent House District 72, which includes the towns of Oxford, Otisfield, and Mechanic Falls. I am here to present LD 1717, an act to ensure home care and hospice providers are included in Maine's emergency response plans. This bill came out of conversations with the Home Care and Hospice Alliance of Maine during the COVID-19 pandemic. Providers of home care and hospice services in Maine were on the front lines of the pandemic, treating patients in the community, including many COVID positive patients, which helped keep people at home and out of our acute care hospitals. These services were a critical part of Maine's collective response to COVID-19. Despite the important services they provide, home care and hospice providers were not initially part of the state's emergency pandemic response last year. As Maine CDC and Maine Emergency Management began distributing PPE and testing supplies to healthcare agencies last spring, home care and hospice providers were left off the state's list of providers for distribution. Home care and hospice providers that are part of larger hospital systems were able to access supplies, but independent agencies struggle to obtain critical PPE and testing supplies. These agencies were left to determine how to equip their staff and whether or not to send employees into dangerous situations without protection. Some administrators were driving across the state to meet colleagues in parking lots to pick up critical supplies. In addition to the struggles provided experienced accessing PPE and testing supplies, some workers in the home care sector also lacked access to the vaccine when other healthcare workers were receiving priority. Employees classified as PSS workers, personal support specialists, provide critical in-home supports such as bathing, toileting, dressing, and eating to older and disabled people across Maine. However, such employees are not considered essential healthcare workers and were therefore left out on the first phase of vaccine distribution. While in the midst of a public health crisis, of course, we are not always going to get everything right. Not all aspects of the response were going to go smoothly. That being said, it's not acceptable that agencies that provide critical healthcare services throughout our entire state were left out of the state's initial response plans and distribution efforts. I pray we will not have to deal with another public health emergency like this one anytime soon. But when we do, home care and hospice providers would like to be at the table along with other healthcare providers when the state of Maine embarks upon its response. They would like access to the resources necessary to respond to the public health emergency in the same fashion as other healthcare providers when the state is distributing those resources. I believe that captures the intent behind this legislation. I would like to draw your attention to an amendment that I have provided to you today to make slight changes to the language in this bill, but the legislative intent remains the same. If the committee would like to work on additional amendments to achieve the goals of this legislation, I would welcome that. I would also understand that if the committee chose to carry this bill over as we are at the end of the session and there may not be adequate time to determine the best path forward. Members from the home care and hospice sector will be coming before you today to share their experiences. I thank them for all of their tireless work they have put in over the last 14 months to respond to COVID-19 pandemic and care for our families, friends, and neighbors in our communities. Thank you for your time. I would be happy to answer any questions you may have, but there may be better suited those testifying from this sector of our healthcare workforce.
Thank you, Representative Connor, for bringing forward that testimony. Are there any questions to direct to Representative Connor? Not seeing any. We'll proceed to hear from folks in support of this legislation, and we've been asked if we couldn't start with Lori Belden. Welcome.
Good morning. Good morning, Senator Claxton, Representative Myers, and members of the Joint Standing Committee on Health and Human Services. And thanks, Representative Connor, for my testimony. It's going to sound very similar. So I'll just hit the high points. I am the executive director of the Home Care and Hospice Alliance of Maine, and our members are statewide and provide services in the home from bathing and dressing to skilled nursing and therapies, all the way to care at end of life. We appreciate this opportunity to support LD 1717. I'd like to start by acknowledging the swift response by the administration, Maine CDC, and the Maine Emergency Management Agency to protect us all from COVID-19. The governor's prompt response and decisive actions, along with those others who are overseeing the public health plans, surely saved countless lives across the state. I'd also like to thank Representative Dillingham and Liaison Representative Connor for hearing our concerns and about the significant imparity in Maine's emergency response plan and bring it forward in this bill. From the start of the pandemic, we were acutely aware that in the importance of keeping older Mainers in the home. The caregivers were literally a lifeline to these vulnerable patients who were and still are at increased risk for developing serious complications from COVID. It was also evident early on that in-home care wasn't considered an essential healthcare service, which led many of our providers to be denied access to personal protective equipment and rapid testing for our frontline workers. It also affected access to the vaccinations when the priority lists were being rolled out across the state. In Representative Connor's telling of Dillingham's testimony, we talked about meeting up in parking lots. I was the fortunate one to be able to hustle some PPE from out-of-state companies. I worked with Senator Collins' office. I worked with New Balance to do whatever I could on behalf of our members, and drove statewide to make sure those masks landed in the hands of those that needed it most. I am just yesterday, which is good timing, I was contacted by the Health Coalition of Maine, who is the contractor for the state, who develops the, who coordinates coordinates the healthcare emergency preparedness and response services. We've been actually invited to be part of the coalition and be part of their, they call it the after action report. So they're going to kind of look back and see what worked and what didn't. And we're going to be part of that conversation. So we are very optimistic about being part of that assessment. And hopefully by being at the table, our in-home and community support services will finally be fully integrated in future emergency preparedness plans. I've never been more proud to be representing this agency and these providers who really push through severe adversity to keep people safe in their home. We hope never be faced with a pandemic such as COVID-19. Yet this pandemic did really reinforce the benefits and undeniable value of keeping patients in their home and supporting in-home services. When it comes to the healthcare continuum during a public health emergency, we've proven that we're stronger when working together: acute care, facility care, and in-home care. And for that reason, we asked you to please support LD 1717. And I'm happy to answer any questions. And I just want to let you know that we do have some providers coming up to testify right behind me that can really delve into more of their experiences and challenges they face. So thank you again for your support. And I'm with you. Glad it's Friday.
Thank you for that testimony.
Thanks.
I don't see any questions. So next we'll go to Clara McConnell. Good morning. If you want to unmute and join us, there we go.
Good morning, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. My name is Clara McConnell. I am a government affairs consultant at Main Street Solutions, and I have the distinct pleasure of working with the Home Care and Hospice Alliance of Maine and their members with their government affairs work. So we had a little bit of trouble with some members rearranging their schedules this morning for this quick public hearing. So I am just going to be delivering testimony on behalf of a member, if that is okay with you.
That'd be fine.
All right. Thank you, Chair Claxton, Chair Meyer, and members of the Joint Standing Committee on Health and Human Services for this opportunity today to bring attention to the importance of the inclusion of home care and hospice providers in Maine's emergency response plans. My name is Jeff Johnson, and I am the Director of Operations for Bridges Home Services, a division of Spectrum Generations. Spectrum Generations operates Bridges Home Services, which has provided in-home care and community supports to older and disabled citizens for more than 25 years. Bridges is a registered personal care agency, a licensed adult care and community supports program, and has a current workforce of more than 200 direct care and administrative staff, providing over 180,000 hours of Maine Care services each year. In addition to Maine Care consumers, we proudly serve Maine citizens who qualify for services through the Department of Veterans Affairs, through a partnership with the Wounded Warrior Project, as well as those who pay privately. Through the COVID-19 pandemic that our state has and continues to endure, Bridges Home Services has fought to keep its doors open in order to provide care to our consumers. Although our agency does not provide skilled care, our services remain crucial to our consumers, especially during this pandemic. Some need moderate levels of help with activities of daily living. Many need high levels of care in order to avoid a hospital stay or placement in a facility. The very directive by the state was for citizens to remain in their home during the pandemic, and our consumers relied on us to ensure they could. In order to do that, our agency had an obligation to provide the necessary PPE to our staff and consumers in order to keep them as safe as possible. When ordering these products through retail and wholesale channels became no longer an option, we turned to the state stockpile in order to obtain items like masks, face shields, and hand sanitizer. We quickly learned that agencies like ours did not meet the essential business guidelines for PPE. It left us to turn to volunteer efforts to make homemade masks and to donations of hand sanitizer from local distilleries. What has become apparent over this past year is that the state must recognize home care and hospice providers as essential to the well-being of our most vulnerable citizens, particularly during periods of health emergency. Ensuring these providers are included in the state's plans ensures that when the need arises, agencies like ours are supported and vulnerable citizens are not left without care. I strongly encourage the committee to pass this bill. Thank you for your time.
And thank you for that testimony. Thank you for being here. And we've all had to adjust our schedules a bit on the fly as we've gone along at this point in the session.
Absolutely.
Are there any questions for Clara McConnell? I don't see any. Before we go to Elizabeth Hart, I want to give Senator Baldacci a chance to introduce himself. I should have done that about 2 testimonies ago.
Well, it's all right. Thank you, Mr. Chairman. I'm Joe Baldacci. I represent State Senate District 9, which is the city of Bangor and the town of Herman. Thank you. And good morning, everyone.
So now we can hear from Elizabeth Hart.
Thank you. And I also am testifying on behalf of somebody whose schedule did not allow him to change as quickly as possible. I hope you will not mind my reading testimony from Kenneth Albert. I'm Dr. Elizabeth Hart, Director of Medical Services and Hospice Medical Director for Androscoggin Home Health Care and Hospice. And if that would be okay, I would proceed to reading Mr. Albert's testimony.
That would be very helpful.
Thank you. Senator Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Kenneth Albert, a resident of Lewiston. I serve as President and Chief Executive Officer for Androscoggin Home Health Care and Hospice. We're a state licensed Medicare and Medicare certified provider of professional skilled health services for more than 180 Maine communities across 9 counties, navigating healthcare for over 2,500 Maine residents every day with 500 employees. Thank you for the opportunity to testify in favor of LD 1717 as amended today by Representative Dillingham. For context, I serve as a member of the Board of Directors for the Home Care and Hospice Alliance of Maine. I'm also an elected member to the Board of Directors for the National Association for Home Care and Hospice, the largest advocacy organization representing home health care and hospice providers in the US. This is relevant to the extent that I'm in a position to attest to the fact that the substance of LD 1717 serves to address grave concerns that home care and hospice providers faced here in Maine and across the United States as we endeavored to administer healthcare at the outset of the public health emergency. Specifically, the federal emergency management guidance that informed the practices in many states, including Maine, failed to include home health and hospice providers in a tiered priority list for state cash resources for personal protective equipment like N95 masks, gowns, and sanitation wipes, face shields. As traditional supply chains for these resources dried up almost immediately, most home health care and hospice providers struggled for weeks to gain access to basic equipment necessary to keep employees and patients safe while providing health care in the home. Maine's COVID personal protective equipment resource request and tiered prioritization guidance for the COVID-19 public health emergency read as follows, with tiers including, and I won't read the full details because of your time, but the tiers included Tier 1, clinical first responders and EMS and hospitals, Tier 2, urgent care and outpatient clinics and federally qualified health centers, Tier 3, long-term care facilities and assisted living and nursing homes, and Tier 4, non-clinical first responders. As the Chief Executive Officer, ultimately responsible for the health and safety of our employees and patients, I have never felt so helpless, and I never want to be in that position again. I was finally fortunate to gain the attention of leaders within the Maine CDC and Maine Emergency Management. Once our plight was realized, with agreement that we were not included in the foregoing tiers, they were incredibly helpful in making sure our employees had the equipment they needed. That said, that was not the experience for all Maine providers. Further, the same assistance that Androscoggin received in Maine did not result in some other states for months, leaving many home health clinicians to use trash bags over their uniforms as a poor means of protection. We must never again find ourselves in this position. You may ask yourselves whether protective equipment was even necessary at the time. I assure you it was. Maine providers, in collaboration with the Home Care and Hospice Alliance of Maine, collected vital data beginning in April of 2020. The attached COVID-19 trends, which is a report which is a supplement to my testimony, provides the analytics associated with the care of COVID-19 positive patients and patients under investigation who were being tested, who were cared for in the home by Maine's home care and hospice providers. I won't address all of the data of the elements in this testimony, but a few key points are worth referencing for your consideration. This is data from April 2020 to March of 2021. 1 in 6 COVID-19 patients in Maine have been served by a home health or hospice organization. For those COVID-19 patients requiring healthcare services, 16%, or 9,086, were cared for by a home health or hospice provider, thereby preventing admissions to hospitals who were diligently caring for 3%, or 1,789, of the emergently ill COVID patient population. As we continue with the current public health emergency, I don't even want to conceive of the potential for another, but as a healthcare leader, I must. As is always the case in a public health emergency, healthcare providers of all disciplines and types are called upon to care for the citizenry impacted by the given disease causing the emergency. It's entirely appropriate that Maine's governor would consult with healthcare providers in all relevant settings to make sure that we have supplies and equipment necessary to administer safe and effective healthcare. LD 1717 will serve that end. Please support this effort. Thank you for this opportunity. I also thank Dr. Hart for reading this testimony on my behalf. I will be happy to be available as a resource during the work session. And I would also be happy to be available for any questions now, and Mr. Albert will join you later as needed.
Thank you, Dr. Hart. Are there any questions? So as I understand it, Androscoggin specifically felt at some point that they were adequately included in the conversations, although it took longer than it would have had this legislation been in place.
Yes, and I think we are very fortunate that being an organization that is so embedded in the larger network in terms of the Home Care and Hospice Alliance and our Chief CEO President's ability to interact with the Maine Emergency Management and the Maine CDC, that we were uniquely well positioned to make that case so that our needs were met. It was a challenge, and we certainly have providers reusing equipment that in any other healthcare situation we would not be reusing, but that was the unfortunate reality. But with that advocacy, we were able to care safely for patients and a large volume of patients as we continue to in the home setting.
Thank you. Thank you for continuing to the proud tradition of medical director for AHCH. I've worked with all of them over the years.
Well, thank you. I very much appreciate it. And it's really been an honor, and thank you very much for this opportunity.
Okay, not seeing any questions. Looks like we can proceed to Lisa Harvey McPherson. Good morning.
Good morning. Good morning, Senator Claxton, Representative Meyer, and committee members. My name is Lisa Harvey McPherson, and I'm here today to speak in support of this bill on behalf of Northern Light Health. I am so pleased that my colleagues went before me today, because you're going to hear a story of true disparity of what it was like to do home care, part of a health system, and you've heard what it was like and the challenges when you were an independent agency. Like my colleagues, our home care and hospice team were integral in caring for patients at home. Our home care team cared for 380 COVID patients throughout the state of Maine, making sure only the most acutely ill COVID patients were hospitalized in our member organizations. Our hospitals cared for 432 COVID patients, so almost the equal number were cared for at home. But home care had a far larger role than simply caring for patients at home, which was very important. Our home care team was integral in our community response to the COVID pandemic. Early on, when the pandemic started, we deployed home care nurses to homeless shelters with tablets, and we would connect the homeless patients in the shelters via telemedicine to primary care doctors. So we cared for them in the shelter, never transporting the homeless to our emergency rooms. Later, when the communities and public health set up homeless individuals that were COVID positive in certain hotels to cohort them, our home care team was there every day monitoring these patients and caring for them. Early on, before we had the swab and send sites, we didn't have the capacity to do mass collection of swabs to test for COVID. Our home care team was deployed to nursing homes, senior living complexes, residential care facilities, and businesses. We swabbed thousands of individuals before the swab and send sites were established. Later, as COVID expanded in our nursing homes and our residential care facilities, some facilities became overwhelmed. They did not have the clinical capacity to meet the patient needs because their staff too was experienced the symptoms of COVID. So our home care team became an emergency response team, and we went into facilities and provided staffing and support to help stabilize those facilities so patients once again weren't overloading our hospital systems. As vaccines became available, we set up mobile vaccine clinics, and I actually helped work in those clinics. It was an honor to do so. And we also established vaccines for homebound patients. So whether or not they were in our service, we vaccinated hundreds and hundreds, and continue to do so, of patients who are homebound and can't get to community clinics.
30 seconds.
Now, we now expand to cover school-based clinics. That's what it was like to do home care in a health system. We had PPE, we were integrated into the community response, and our employees were vaccinated as essential providers. And you've heard the story and the challenge that my colleagues experienced, and it wasn't right. But we don't know exactly how it happened. The governor's declaration in May included home care and hospice as essential providers. And the MEMAS site has a plan that talks about COVID-19 healthcare response, and you see home care and hospice in that plan. So how we failed on execution, we're not sure, but we clearly brought this bill before you today to make sure it doesn't happen in the future. And I welcome any questions that you have, and thank you for the opportunity to share our story.
Thank you for that and for all of the service that your organization and your people have provided. I don't see any questions. I also don't see anybody else who would like to testify for, against, or neither for nor against related to LD 1717. So we can conclude the public hearing portion of our consideration of this bill. Or is there information that any of the members of the committee would like to have available for a work session? I'm not seeing any particular questions. All right, then that will conclude our work on LD 1717 for now. At this point, we can proceed to LD 1718, consideration of that bill. And I understand there's one speaker to address this bill, or a second one has showed up too. Welcome. So somewhere in there it is. There's Gordon Smith and Dr. Evans. Welcome.
Well, thank you. If I may proceed, first of all, good morning to everyone. Good morning, Dr. Claxton, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. I am Richard A. Evans, and I represent 7 communities in Piscataquis County. I am here today to introduce LD 1718, an act to establish the Accidental Drug Overdose Death Review Panel. As you are aware, overdose deaths are a very serious problem for Maine. And as a state, we need to be doing all we can to prevent these deaths. In 2020, Maine recorded its worst year for drug overdoses with 504 deaths. Since January of the current year, we continue to be on a sustained upward spike that has worsened since the start of the pandemic. As a state, we are committed to doing everything we can to prevent this trend and its unfortunate effects on the families of Maine people. One way to help prevent those deaths is to examine the circumstances in the victim's life leading up to their death, and to see whether there were opportunities to change the trajectory of their lives, and if so, what those opportunities were. This sort of study is what commonly happens in other areas. For example, the state already has the Maternal, Fetal, and Infant Mortality Review Panel, which was established by statute in 2005 to study ways to reduce pregnancy-related deaths. 33 other states already have similar panels to study overdose-related deaths, including New Hampshire, which set their program up this past year. This bill, LD 1718, was already heard last year, but unfortunately, work on it was halted due to the pandemic. I will be followed by Gordon Smith, our state director of opioid response, who will go into the background on this bill and answer any questions that you may have. So I thank you for your consideration, your willingness to address this very serious issue, and your support. Thank you.
Thank you, Dr. Evans. Are there any questions for our colleague? I don't see any. So we can hear from Gordon Smith. Good morning.
Good morning, all. Senator Claxton, Representative Meyer, and members of the committee. I am testifying this morning from the elegant confines of the Cross Office building again. I am Gordon Smith, a resident of East Winthrop, and I currently serve as the state's Director of Opioid Response. I appeared before you today in support of this governor's bill, LD 1718. I appreciate very much Representative Evans' sponsorship of this bill, which I drafted about 2 years ago. I consider the bill to be a very important part of the state's response to the opioid epidemic generally and to the recent spike in overdose deaths specifically. The recently updated opioid response strategic action plan, which you were so kind to provide me an opportunity to brief you on a few weeks ago, explicitly states in strategy 1, current activity H, quote, support and implement if enacted legislation establishing an overdose fatality review panel, end of quote. Next week, Attorney General Aaron Fry is expected to release the annual report of drug overdose fatalities for 2020. He will also release the monthly numbers for March of this year. There will be no surprises in these reports, as the quarterly reports in 2020, which are available on the new main drugdata.org data hub, confirm that 504 individuals died last year from drug overdoses, a sharp increase from 2019. And the first 4 months of this year has shown little improvement. LD 1718 is one of the initiatives being considered as we ramp up our efforts to keep Mainers alive. Others include implementation of the options initiative in each county and continuing distribution of the life-saving drug naloxone. We're also educating people who are using drugs to not use alone, as the majority of overdoses currently have no bystander to administer naloxone. More education on the Good Samaritan law enacted last session is also taking place in order to encourage individuals present at an overdose to call 911. This bill creates within the Office of the Attorney General an accidental drug overdose review panel to review a subset of overdose deaths. The deaths reviewed would be recommended by the Office of the Chief Medical Examiner and its contractor, which is at this time is the Margaret Chase Smith Policy Center at the University of Maine, led by Dr. Marcella Sorg. Marcy is a forensic anthropologist. I drafted the bill after reviewing all the current laws in Maine establishing similar panels, such as the Maternal and Infant Death Review Panel, which Dr. and Representative Evans mentioned. These panels operate in similar ways, and these authorizing statutes are required in order to allow the panels to review materials that might otherwise be considered confidential and to protect the confidentiality of their deliberations. The proposed statute also stipulates the 14 individuals or their designees who would serve on the panel. Other states have similar panels, which have been considered an effective strategy in preventing overdose deaths. The New Hampshire legislature enacted a similar bill in 2019, and I've been in touch with them about their processes and work. Over 30 states have similar panels. There is now quite a robust exchange of information across these states so that an array of best practices is evolving. Along with some of the research team at the university, we've been attending some of the conferences virtually in order to be prepared should this bill pass. I hope it will, as I have no doubt that there are things we can learn from the circumstances surrounding every death. And this learning may cause us to pivot in some of our policies where we find gaps that can be filled. You will note that the bill has an emergency preamble so that we can begin our work immediately should the bill be enacted and signed into law. So long as we continue to lose 10 to 12 Mainers every week, I can't imagine a bill more directly impacting this session on life or death. In the way of background, I think you should be aware that this identical legislation was considered by the Judiciary Committee last year. And a work session last summer resulted in some amendments, which I incorporated in this draft. I believe the bill had a unanimous pass report anticipating that the legislature might reconvene. But as you well know, that did not occur. So here we are back again. And I would apologize for it being printed and considered so late in the session, but that was not due to any delay on the part of myself or the governor's office or Representative Evans, who signed the bill out 2 months ago, over 2 months ago. Regardless, we're here now, and I believe that most of the interested parties have known of this bill for 2 years and had ample opportunity in 2020 to comment, and all their comments were considered in this draft. Thank you for your time this morning. I'd be happy to answer any questions that you may have.
Are there any questions for Mr. Smith? Since you're so familiar with this legislation, Gordon, can you highlight a couple of the places where the legislation changed from last session to this, incorporating feedback?
Yes, I was prepared for that question, Senator Claxton. I do remember that, and these were maybe 3-4 changes that came up in the work session before the Judiciary Committee. One amendment came from Jeff Austin at the Maine Hospital Association, who encouraged us to clarify the language on page 1 and about line 20 to make clear that these overdoses that we're going to look at are presumed to be self-administered by an individual and excludes an overdose that occurs within a licensed healthcare facility. So that Jeff was trying to make the point that there are occasionally in a hospital drug overdoses that might result in death. That's not what we're looking at. Now, before you ask the question, those are sentinel events under our licensing and under the Joint Commission standards. So just because this panel is not going to look at those deaths doesn't mean that nobody looks at them. That was one change. There was also a provision in the composition of the panel where I had allowed the Attorney General's office or the Governor's office to appoint additional individuals at their discretion. And the committee encouraged me to remove that, which we did. Rachel Talbot Ross, who was on Judiciary last year, we had a dynamic discussion about the racial and ethnic diversity of the state, the fact that in some aspects of our drug policies, certainly in the criminal justice system, we know that there is an uneven impact upon the indigenous population as well as Blacks in the state. And so we added on page 2 in line 9 the following language: in making appointments to the panel, the appointing authority shall take into consideration the racial and ethnic diversity of the state. I think that those were definitely the major ones. If there was anything else, Senator Claxton, they would have been very minor.
Thank you for that background. I appreciate that. The other question I had was about the necessary waiver that would apply in this case, because this would not be a public hearing or a public meeting since it's considering confidential medical information. I assume the Judiciary Committee made sure the bill was written such that they could grant a waiver. Is that a fair assumption?
I hope so. I would, I don't know whether Aaron or Anna have this.
Anna's already shaking her head, so you may be off the hook on that question.
Good. And because Peggy Reinsch, who was the OPLA staff to Judiciary and has been for a long time, did work with me on it last session. So I don't consider myself an expert in the right to know law, but I'm assuming it was taken care of.
Okay. Well, thank you for that information. Are there any other questions for Gordon? Good to see you as always. Welcome. Thank you for being here, Dr. Evans, and for introducing you. I don't see any other folks have indicating an interest in testifying on this bill. I did see Anna shaking her head in response to my question to Mr. Smith.
I only meant that it would still need a public records exception this session because it's a new legislature. But this bill is exactly the same as the amended version that came out of Judiciary during the interim. So they took all those amendments that Gordon talked about and put it in their amendment, and that's been included in this bill. And there was certainly, they do their, I mean, it's kind of a funny idea that Judiciary do a public records exception on their own bills, but they do, but we will have to do it again.
Okay. No, that part I got because I know there's an opening on Wednesday for consideration. So we'll try and move this quickly and not lose that opportunity to get this rolling if we can get agreement amongst the committee members. So thank you again for being here, Gordon and Dr. Evans.
Thank
All
you
right.
for having us.
Is there additional information that anybody would like to have in anticipation of a work start? Oh, whatever, a work program. Work session, thank you. Must be end of session. I'm not seeing any questions. Okay. Now we can proceed with consideration of LD 1722. And we'll look for, I'm not sure who's to present this bill, but we'll include a number of different folks.
Representative Warren will be
Oh, good.
presenting. Yeah.
Okay. And I don't see her on the attendee list, but that maybe she's in the wormhole.
I've just sent a message.
Okay.
Give her a minute, please.
Why don't we take a 5-minute break, reconvene and about 10 of while we wait for her to come so people don't have to sit and wait.
Colleen, are we having a break?
Yes,
How much of a break?
5 minutes.
Thanks.
Welcome, Representative Warren. We can now begin consideration of LD 1722. Happy
Thank you.
Friday.
Thank you. Happy Friday. I apologize that you had to wait for me.
That just gave us a chance to take a break in a otherwise uncrowded and very different schedule, so no problem.
Okay, thank you. Good morning, Senator Claxton, Representative Meyer, and distinguished members of the Joint Standing Committee on Health and Human Services. My name is Charlotte Warren, and I represent the city of Hollowell and the towns of Manchester and West Gardner. Thank you for the opportunity to testify in support of LD 1722, an act to ensure access to all paths to recovery for persons affected by opioids using money obtained through litigation against opioid manufacturers. I can't say that word, obviously. Mainers know too well the struggles and impacts of alcohol, opioids, and other prescribed and illegal drugs. Most of us understand the substance use epidemic personally through the death or near death of someone close to us, a friend, a loved one, a neighbor. Tragically, deaths from drug overdose deaths remain on the rise, and as reported by the Maine Attorney General's report in 2019 and 2020, and the COVID-19 pandemic has only compounded the problem over the past year. The reality is that Maine families and communities across the state and across generations continue to be devastated by the fiscal, social, and emotional costs of untreated addiction. We simply must do more to address all forms of problematic substance use, but to help, we need resources. And you all know that better than anyone in this committee. Other than Nebraska, all states, including Maine, and more than 2,500 municipalities, countries, tribes, and individuals have filed lawsuits against companies involved in opioid drug production, including opioid manufacturers and distributors in their respective state and federal courts. With millions of dollars from the litigation now coming into our state, it's crucial that we establish guardrails and oversight so that we can make the best use of these funds. Specifically, it's imperative for public health and safety that all money received by the state as a result of lawsuits related to opioid manufacturers and distributors be used to help remediate and abate the opioid and substance use crisis. These resources should support all paths to recovery through prevention, intervention, treatment, and recovery services, including access to all United States Food and Drug Administration approved medications for opioid and alcohol use disorders. We should also look to use this money to expand access to other best practices, including managed detoxification, individualized patient assessment, treatment and recovery planning and services, counseling, services for co-occurring mental illnesses, provider education, diversion control, relapse prevention, and adequate reimbursement rates for providers. LD 1722 will protect and direct these funds so they are used effectively to address the very problems created by the defendant drug companies, ensuring that the treatment and recovery systems for patients with OUD and SUD are seamless, easily accessible, and individualized to meet patients where they are in their recovery journey. Despite the increased awareness of the SUD crisis in our state, our current treatment and recovery system continues to be underfunded. These additional multi-year resources could prove vital in our ability to finally get a hold on this epidemic. And let me just give you a few details. LD 1722 establishes a dedicated trust fund to receive and house the monies. It establishes a multi-stakeholder council to determine how settlement monies are spent. It identifies what the settlement monies are to be spent on. It ensures that settlement monies do not supplant programs. In order to remove barriers to care and to support all paths to recovery, the bill directs the litigation funds to support, for number one, access to the full continuum of care, including screening, assessment, evidence-based services in all treatment and recovery settings through capacity building and successful transition of care in hospitals and in emergency rooms, in detox facilities, and in inpatient residential and outpatient settings, primary care, community health and mental health centers, correctional facilities and community supervision, recovery housing, and other recovery and community support services. It also provides access to all treatment options. I spoke about that above, so that treatment is individualized, comprehensive, patient-centered. It also provides that adequate and appropriate reimbursement for all evidence-based services throughout the continuum of care, something you all work on very closely in this committee. It also provides access to services in communities with geographic and transportation barriers. Since we know it is critical in a rural state like Maine that we establish treatment options that include the full range of psychosocial supports and MAT in areas with geographic and/or transportation challenges, appropriate reimbursement for mobile health services, telemedicine, and pharmacist administration of certain medications, particularly in rural areas, will help us expand access to needed services throughout the state. And finally, statewide education for healthcare providers and community organizations. This provides providers and community recovery organizations so that they can be fully educated and resourced to offer all evidence-based options and recovery supports. Because of the dire nature of this crisis, again, you've heard me say it before, 11 people will die this week in Maine from overdose deaths. I have introduced this bill as an emergency. My hope is that we can enact this legislation so that the money, some of which is already sitting in an account, can be accessed immediately and put to use to help save our friends, colleagues, and community members who we are losing at a rate of more than one per day. These settlements represent a once-in-a-lifetime opportunity to improve the treatment and recovery systems for those suffering from OUD and other substance use disorders and co-occurring mental health disorders. We implore you to ensure that these monies are protected, that they do not supplant current budgets, and that they provide access to comprehensive patient-centered treatment. I thank you so much for scheduling this bill in these late days and for your consideration. I'd be pleased to answer any questions.
Are there any questions of Representative Warren? I don't see any, so thank you for bringing this forward.
May I add one thing? I apologize.
Sure.
If it's okay with you all, there will be an amendment today by the allies that I'm working with. It's a friendly amendment. And could, if it's okay with you, could Ms. Courtney Allen present after me and provide you all with the amendment?
We try to be accommodating, certainly.
Thank you. Thank you.
Representative Griffin had a question.
Sorry. Thank you. I just wondered if Representative Warren, if you're, I don't see your testimony on the list.
It's uploaded. It may be taking a while to get there, but thank you. I did upload it late, but it should be there soon.
Okay, so we will go to Courtney Allen. Good morning.
Good morning, Senator Claxton and Representative Meyer and all the members of the committee. I did upload 2 versions of my testimony, and I asked you to reference the testimony that says updated. I apologize, everything is moving very quickly, and I wanted to ensure that you had my most updated thoughts on this matter. So my name is Courtney Allen. I am the Policy Director of the Maine Recovery Advocacy Project. I'm here today to testify in favor of LD 1722 on behalf of our network. Our community includes people in recovery, people who use drugs, family members, and our allies across the state. This bill seeks to ensure that the recovery community has a seat at the table as decisions are made on how to spend opiate litigation funds in our state. This could not be more important to our community, as we are the people who have endured the most harms at the hands of opiate prescribers, and therefore should be included in the conversations about how to spend that money. Time and time again, our community has been left out of decisions that directly impact us, and we ask your committee to ensure that does not happen again. We do hope that the Attorney General will consider non-traditional voices from our community and seek to include a diverse representation of the recovery community as appointments are made to this commission. Non-traditional voices may include people who have never been served on a commission or who identify as a person who uses drugs, among others. We believe that the collective responsibility of recovery advocacy and service to our movement should be delegated throughout it and not on the shoulders of just a few advocates. We also believe that the opiate settlement fund should be overseen by a separate entity than the Substance Use Disorder Commission. The recovery community, again, is a diverse community, and therefore we should always try to include as many of our voices as possible. The commission, this commission also seeks to expand representation of voices that are not represented on the Substance Use Disorder Commission. These additional voices include the Attorney General, who has been directly involved in securing these funds, the Commissioner of Health and Human Services, the Director of Opiate Response, a member who represents families impacted by the opiate crisis, a member representing reentry supports of formerly and currently incarcerated people and their family, a member representing pretrial services, 2 members representing the municipalities impacted by opiate and substance use disorder crisis. And we have met with a wider coalition of recovery advocacy organizations yesterday, including the Health Equity Alliance, Maine Prisoner Reentry Network, Maine Prisoner Advocacy Coalition, and others to review the language of this bill. We are collectively proposing a friendly amendment to the language for your committee to review. We have recommended that a few additional appointees be added to include a member representing harm reduction services and 3 members at large representing geographically diverse areas not currently included or represented on the commission.
30 seconds, Courtney.
Thank you. These recommendations are to ensure that all stakeholders are represented, including geographical distribution. We're also recommending that language be added to the bill to ensure a collaborative effort between this new commission and the Substance Use Disorder Commission. Our proposed language changes will be attached to my updated written testimony. We urge your committee to refrain from holding this bill over to next session and to act now. Opiate settlement money is already available in our state, and other monies will be coming soon. We worry that if you wait till the second session, that the money could be spent without the input of our diverse stakeholding group. We ask that you protect this money now by voting ought to pass as amended. Thank you for your consideration, and I'm happy to answer any of your questions.
Thank you. Are there any questions from this testimony? I don't see any, Courtney, so thank you for being here.
Thank you for your service.
Next, we'll go to Bruce Snowden.
Thank you, Senator Claxton and Representative Meyer and the members of the Health and Human Services Committee. My name is Bruce Snowden. I'm the Executive Director of the Maine Prisoner Reentry Network. And I'm a person in long-term recovery. I think maybe that's probably the most important thing that I bring to this conversation. I'm writing to express my full-throated support for LD 1722. In addition to NPRN's role as a support and resource connector, NPRN assembles and represents a statewide network of literally hundreds of organizations committed to supporting returning citizens from jail and prison. For this reason, we support LD 1722 because it promotes the same statewide community collaborative spirit. I saw it yesterday in the groups that Courtney Allen and others had assembled. As a person who came from the business community and into the nonprofit world, I was kind of appalled by the battle that goes on between nonprofits for funding. And in recent years, I've seen this wonderful kind of community collaborative taking place that we're not directly responsible for, but we do participate in. Organizations like MERAP, John Sarbeck's CCC SUP group that he has in Cumberland County, Healthy Acadia's groups that are run in Washington and Hancock County, Somerset County Collaborative, and our MPRN statewide convenings, all are ready and fertile for funding to be dispersed evenly and fairly, but also for all of us to work together on this crisis. And it's not just a crisis of the opioid epidemic, it's also a crisis of substance use disorder. Most folks who unfortunately pass away from overdose of either heroin or fentanyl or other related substances also have other substances in their body, most notably alcohol, methamphetamine, cocaine. And I really appreciate the approach of this particular bill to say substance use disorder, not just opioid use disorder. And for it to promote in just the way that it's set up in the geographic distribution and distribution of life experience, to just promote collaboration, and that we're not battling for pieces of chunks of money so that we can exist and do our work. I really appreciate this kind of collaborative spirit that's created by this bill. So we wholeheartedly support 1722. Thank you.
Thank you. Yes, Representative Craven.
Thank you, Mr. Chair. I just wanted to say hi to my friend Bruce Naughton and say thank you so much for all of the work that you're putting into this. Nice to see you.
Thank you so much, Margaret.
Any other comments or questions? Not seeing any, we'll proceed to hear from Bruce Campbell. You're unmuted. Now we can see you.
Okay, thanks. So thank you, Chair Senator Claxton and Representative Meyer and members of the Committee of the Joint Standing Committee on Health and Human Services. I am going to read this because I just wrote it. Don't have it committed to memory. So my name is Bruce Campbell, and I began my professional career in 1976 as director of the Aroostook County Halfway House, a correctional facility. It's a work release program operating out of Aroostook County Jail. When I left that program in 1982, my only regret was that we never dealt with substance use disorders among our clients, our residential clients, because 90 days after their release, they would be back in jail because they got drunk or stoned and did something stupid. I went to California and began working in residential programs for young, emotionally disturbed children, and later with adolescents with substance use disorders. I went back to graduate school focusing on cross-sector social work practice, receiving my MSW degree in 1990. For 5 years, I was the policy and planning and program development analyst for Monterey County's alcohol and drug programs. Then for 9 years as the senior analyst for Monterey County's child welfare program, assigned to the out-of-home care system. This led me to a consultant role with the National Center on for Substance Abuse and Child Welfare, and I served in that capacity for both Massachusetts and Maine as we moved back from California to Maine in 2004. When we returned to Maine, I began working as a clinician at Acadia Hospital's methadone program, then worked for Wellspring in Bangor as its clinical director for 11 years. overseeing the clinical operations of its men's house, women's house, Infinity House for women and children, and detox center. I provided clinical oversight to the implementation of treatment for Penobscot County's drug court, as well as the treatment partners in Maine's Title IV-E demonstration project, the Maine Enhanced Parenting Program. I administered the treatment components for the Penobscot County Drug Court, as I mentioned, and supervised Wellspring's outpatient substance abuse and mental health programs. But none of this would have been possible without my own recovery. And this August, I will celebrate my 37th year in recovery. I'm also very proud to say that I am one of the founders of the Bangor Area Recovery Network, the first recovery community center in the state of Maine. I say this with a
30
I've
seconds.
got 30 now. Okay,
Yeah.
I got to wrap it up. I say this because in the context of reading Maine's behavioral health plan yesterday, I've never seen us be on the brink of such broad and potential systemic change. And this particular bill kind of ensures that by broadening it to substance use, by creating a lockbox for these funds, because otherwise there would be a feeding frenzy to get a hold of them. And the weakness that I see is that in addition to not supplanting it, we really need to create a policy of reinvestment. And if we do that well with the revolving fund that's included in this bill, then we're not just talking about the money that we get until this runs out, but we're talking about a funding stream in perpetuity for our service delivery system for women, for families and children and parents and everyone. And so with that, I'm sorry I had to race through the last part of my testimony, but I'd be glad to take any questions.
Thank you for that testimony and for sharing your portion of that story. Are there any questions of Bruce Campbell? I don't see any, so we'll thank you for being here.
Sure, thank you.
Next, we'll go to David Getchell. Welcome. As soon as you're unmuted, there you go.
Good morning, Senator Claxton, Representative Meyer, and distinguished members of the Health and Human Services Committee. I don't have anything written, so I'm going to go a little bit off the cuff today. I probably won't be 3 minutes, keep you guys moving along. But I wanted to share a quick story. Maybe about 10 years ago, I had my car broken into and some stuff stolen out of my car. And the person who did that was ultimately caught, and they spent some time in the carceral system. I'm not actually sure what happened to that person, but I never received any of my stuff back. I never received any sort of like conversation with that person about what happened here, like why they stole my stuff. And the point of this story that probably doesn't seem like it's going anywhere is that we don't have a justice system that like delivers justice. Like that person stealing my stuff and then us sending him to jail for that didn't help him. It didn't give me my stuff back. And that's the system that we currently have set up, where we don't deliver justice to people who've been harmed. But with this bill, we can deliver justice to the people who've been harmed most, because we can take this money from this opioid settlement and give it to the people who need it. Now, I have multiple loved ones who have substance use disorder, and they're in multiple different places on that path. And I've had loved ones who've had to search help in other states because they were denied a bed here in Maine. They weren't allowed to get into a detox facility at the time. And like, we've increased our capacity some since that time, but not enough. And so what we desperately need is funding for these places. And it's detox facilities like we talked about. It's recovery, it's halfway houses, it's all of these things, because like we've heard other people say, it's multiple pathways. But the point is that if you guys get together and do ought to pass on this bill, we can make sure that justice is served to the people who've been harmed. That's pretty much all I got. And if you have any questions for me, I'm happy to answer them.
Thank you for sharing that story and that perspective. That's why we have these public hearings. Next, we'll hear from Chris Hall.
Good morning, everyone.
Good morning.
I'm going to read my comments because I've just written them. So thank you, Senator Claxton, Representative Meyer, and members of the Health and Human Services Committee. My name is Chris Hall. I'm a program manager in health professions education at the University of New England. And as you may know, UNE trains many students in health professions. We have 15 or 19 different health professions we train, and many of those students choose to practice in Maine, and we take this responsibility very seriously. Because no one gets away with just one job these days, from 2016 to early 2020, I also served as the program manager for a 3-year grant totaling $870,000 from SAMHSA to train our health profession students in SBIRT. SBIRT stands for Screening, Brief Intervention, and Referral for Treatment, and is an evidence-based practice used to identify, reduce, and prevent problematic use, misuse, and dependent on not only illicit drugs, but also alcohol. As part of that grant and in collaboration with the city of Portland, UNE began to host a harm reduction conference. We did that for 3 years, and it was attended each year by over 300 students and faculty from our health professions training programs, as well as practitioners from across the state. And our ability to bring harm reduction to those students was well received by faculty and really transformative for student learning. Harm reduction is not something that is a traditional topic in health professions education. And for myself, it has helped me and my family support a loved one who is in recovery from alcohol. So I'm here to support LD 1722. I don't want to happen to this money what happened to the smoking cessation funds. And as you know, the primary consideration for this bill is to make sure these funds are used to abate the harm done by disingenuous promotion of opioids by their manufacturers and subsequent over-reliance on them by prescribers, health professionals, leading to the second pandemic that we're in the middle of today. So I'm saying that harm abatement is harm reduction. Representatives of the harm reduction community across Maine must be at the table when these funds are dispersed. And additionally, I feel strongly that some members of that committee have to be healthcare providers. Most of the bullets under what the bill is saying are about the responsibilities of healthcare providers. They still need to prescribe opioids for certain kinds of pain. And they deal daily with the fallout of misuse, either in acute situations like emergency rooms or dealing with the long-term consequences to the health of individuals, families, and communities. So they need to be taken as well. Thank you. The development of the trust fund and a thoughtful and inclusive selection of board members will help to assure the best possible use of these funds. And I liked someone earlier mentioned that it needed to be collaborative and not competitive, and I definitely agree with that. And I encourage you to move forward with the bill and its amendments presented today. I appreciate your time and consideration. I'm happy to answer any questions.
Thank you for that testimony. I'm not seeing any questions at this point, so thank you again for being here. And we'll go to Mallory Shaughnessy.
Good morning, Senator Claxton, Representative Meyer, and esteemed members of the Standing Committee on Health and Human Services. I am Mallory Shaughnessy, a resident of Westbrook and the Executive Director of the Alliance for Addiction and Mental Health Services. And I'm here on behalf of the Alliance to speak in support of LD 1722. We want to thank Representative Warren and Senate President Jackson for bringing this legislation to you today. We also understand that there was an amendment to the initial legislation and are in support of that version and would pretty much agree with most of the testimony that you have heard already. This bill would direct all funds awarded to the state of Maine through opioid litigation and settlements into this opioid and substance use abatement fund. We're very happy that it expands to substance use in general, to be administered by the Attorney General for the purpose of remediating and addressing the substance use crisis in Maine through prevention, intervention, treatment, and recovery. I'd like to point out that Maine does have a precedent for doing this type of dedicated fund and a track record to show the positive impact it has had on Maine. When Maine's share of the Tobacco Master Settlement Agreement was set to arrive, the 119th legislature, boy, that's a long time ago, acknowledged the special purpose of the money and created the Fund for a Healthy Maine, with its evidence-based public health categories on which the tobacco dollars would be spent. There are countless data points today to show the good this has done and the positive impact it has had to improve public health in Maine. Much like the Fund for a Healthy Maine was established to do good in Maine and was built on the settlement funds for misdeeds and misleading advertisements and statements by tobacco companies, we have the opportunity to do good in Maine built on the settlement funds for misdeeds and misleading advertising and statements by some pharmaceutical companies. And I'm sure that similarly to the Fund for a Healthy Maine, there will be a need to have advocates to protect the fund and to make sure it remains true to the intent of its creation, and to assure that it is not siphoned off into a myriad of other purposes into the general fund and other funds. To that end, the bill does establish the Maine Opioid and Substance Use Abatement Advisory Commission, as you've heard, with funds to carry out the purposes of that mission. The amendment has expanded the membership. We agree with that, including more stakeholders and assuring that all parts of Maine are represented. And it also connects to the already established Substance Use Disorder Commission, which does meet on a regular basis and review and look at issues with substance use in the state of Maine. I like that connection, and I think that's important to tie back to what's already existent. And with that, I will end and say, please vote ought to pass, and do it now to do more good in Maine. Don't put it off to the next session. Thank you much.
Thank you for that testimony. I don't see any questions, Mallory, so I think we're good. Now we can go to Marshall Mercier. Good morning.
Good morning. Dear Senator Claxton, Representative Meyer, and members of the Health and Human Service Committee. My name is Marshall Mercer. I'm an organizer for MERAP and a student of recovery. What I mean by that is that as I walk my path of recovery, I will remain teachable and recognize that I am only a steward of the many pathways of recovery that we collectively represent. I'd like to personally thank the AG for going after the distributors and making this bill a possibility, and Representative Warren for presenting this bill to the table. You are becoming my hero right after my Lord and Savior, Jesus Christ. I'm here today wholeheartedly in favor of LD 1722, an act to ensure access to all paths of recovery of persons affected by opioids using money obtained through litigations against opioid manufacturers. And why not? Well, better way to use that money than on the uncountable victims those drugs produced. I was one of them. I was born with 2 club feet and had multiple surgeries on my legs. And the pain was something that I had become familiar with until I met my best friend, Percocet. Doctors told me not to worry about it. As long as I took them the right way they were prescribed, and I did. But after a while, the pain came back and my old limp started to come back as well. But no worries, right? There was a quick fix for all that. All we got to do is up the dose. Needless to say, there was never enough the dose could be upped to feed the beast that grew inside me. At the height of my Oxycontin use, the craziest thing happened. That was so ingenious. If I was a supervillain, a spotlight was shined into the darkness the drug produced in the not so dark neighbors, and almost overnight become impossible to get those pills. That's where once so easy to come across and conveniently almost overnight heroin was everywhere where it once never was. And I'm not saying this was by design. I'm just saying it was really convenient. But here we are now in position to right some of the significant wrongs that were done to humanity. And you folks have the chance to win us, to help us win a victory for the many nameless victims this epidemic created. We urge you to vote ought to pass, and thank you all for your time spent on all these difficult choices. I'm here to answer any questions I can, and I also support that amendment as well. Thank you.
Thank you for sharing a bit of your journey, Marshall. That's important to hear. Are there any questions? I don't see any, so we can go to Whitney Parrish.
Good morning. Sorry, let me just get things in order. Good morning, Senator Claxton and members of the committee. My name is Whitney Parrish, and I'm the Policy and Advocacy Director for Health Equity Alliance. We are a public health and harm reduction organization that works toward a world where health justice is realized for all Mainers. And I'm here today speaking in strong support of LD 1722 and the amendments that have been presented. As you know and have heard, funds derived from settlement of or damages granted in these lawsuits related to opioid manufacturers are coming to Maine as the direct result of harm caused by opioid and other chaotic or problematic drug use in our communities. We believe it is absolutely critical for these funds to remain in our harmed communities, which span the entirety of the state and should be managed and directed to the extent possible by individuals most directly impacted and those who have expertise in that harm caused and how to reduce it. We believe LD 1722 will accomplish these goals. In my written testimony, I get more in depth on some of the key elements that we're highlighting, though we support the entirety of the bill. And so briefly, section 4, subsection A talks about ensuring access to all USDA approved medications. And we believe this is very important because it does not assume that all people who use drugs problematically use opioids. As has been mentioned, Maine data show us that heroin use is actually decreasing and methamphetamine use is rising. Alcohol has remained a constant for decades and decades. So we need to make sure that our medical response reflects reality. As well, establishing or expanding treatment alternatives that provide psychosocial supports and MAT to expand access in rural areas, including mobile health services, telehealth, and pharmacist administration of medication. As a rural provider, we cannot underscore enough the absolute necessity for agility and innovation in how we deliver services. We need to think beyond brick and mortar establishments so that we can truly meet people where they're at. As well, the prioritization of individuals lacking insurance and financial means or returning to the community from carceral settings. These are some of Maine's most vulnerable residents, especially in terms of overdose death vulnerability. This prioritization is not only important in terms of access to recovery resources, but making sure people stay alive to choose that path in the first place. So we believe that one of the most important parts of this bill is the establishment and composition of the Advisory Commission. And to that end, we obviously very strongly support the addition of harm reduction.
30 seconds.
Thank you. And you know, in my written testimony, which you will have soon, I underscore some of what we do, which is direct with some of our very most vulnerable folks who are actively in drug use and sometimes often act as a portal to a higher level of care. In addition to geographic representation, we also implore the committee to consider racial composition as well to ensure reflection of disproportionate harm. And I'll wrap up right now, and to ensure equity in our governmental processes. So we appreciate the opportunity to speak with you, and I welcome any questions. Thank you for your time and attention.
Thank you for your testimony. Next, we can go to Winifred Tate. Good morning.
Good morning, Senator Claxton, Representative Meyer, members of the Human Services Committee, and especially my neighbor, Representative Colleen Madigan. Thank you for all your hard work and the opportunity to speak with you today. My name is Winifred Tate. I'm a resident of Waterville and associate professor at Colby College and director of the Maine Drug Policy Lab at Colby. We are researching the impact of drug policies in local communities and the experiences of women and people who use drugs and are in recovery. I will not repeat the litany of statistics here to convince you that Maine is in crisis, but we do have a consensus that problematic substance use and substance use disorder are public health problems that require public health solutions. And these solutions require funding, money for recovery centers, which we see a lot of support for, but do not have a fiscal note attached to in this session, for treatment, for harm reduction approaches, for peer recovery coaches, and investment in community supports. The money coming into the state from the ongoing opioid litigations must be maintained in a trust that will ensure it is spent to repair the harm done by these opioid communities and to prevent future harm that is caused by the ongoing lack of treatment, harm reduction resources, and support for people struggling with substance use disorder in the state. This money must not be an excuse to maintain the funding status quo. The money should not replace existing funding, but must be used to expand all pathways to recovery available to Mainers struggling with substance use disorder. And finally, this money must be managed by a commission that represents the full geographic, racial, and recovery pathway diversity in the state, and that is directed by the healthcare professionals who are experts in public health approaches, by the harm reduction providers who are the frontline workers keeping people alive in Maine, and by recovery advocates who have the lived experience and insight onto what is needed in Maine communities to make all pathways to recovery available to all. I support this bill and the proposed amendment as a step towards these goals. We have the opportunity to create pathways to recovery that are desperately needed throughout the state. We cannot miss this opportunity to transform Maine. Please vote ought to pass. Thank you.
Are there any questions for Professor Tate? I had one about the work that's being done at the policy lab. I know we're way too far into the substance use disorder and opioid overdose crisis, but we're new into the reparations recovery. Are there other states that are setting up similar institutions or organizations or structures that you're aware of that we could learn from or partner with in the years ahead?
Certainly, there are many efforts throughout the country to channel this money into, you're speaking directly to the litigation money coming out of the opioid settlement?
Yes.
Yes. So I believe that there are many examples from different states that we could look to. I'd be happy to provide additional research if that would be helpful to the committee. I don't have any, I can't speak off the cuff to those examples, but I could provide additional research.
Yeah. And I just wanted to, if we could have a sense of how many similar sort of commissions have been set up in other states, and if there is at least an informal network of people trying to figure out what to do and how to best manage this money.
Certainly, I can get you that information. My understanding is that the litigation is, as I'm sure you know, very complex. All the states but Nevada have these litigation ongoing. So it's certainly a living process that people are struggling very hard to find the best practices for.
Understood. And we'll probably know what the best practices are in 10 years from what we didn't do right in the prior 10 years.
Well, we have a lot of information right now about where this money can be best spent. And as I said, I think there's a general consensus that it is around supporting all pathways to recovery and supporting all forms of people who are struggling with all forms of problematic substance use.
Thank you for that, and I welcome the additional information. This will be a long-term project.
Yeah.
Hopefully, not too long-term. I don't see any other questions. I invite anybody who hasn't yet testified who'd like to testify in support. As I look through the list here, it looks like we've heard from everybody who is currently signed in. I don't see anybody who wants to testify in opposition, so we can go to Attorney General Fry. Good morning, and hear neither for nor against.
Senator Claxton, Representative Meyer, members of the HHS committee. Good morning. My name is Aaron Fry. I did term this as neither for nor against, but I think really it's more of a supportive, it's really more to support the effort to do something like this. Because my job as Attorney General is really just to ensure that the resources are obtained. And I need the help of the legislature to ensure that these resources, once obtained, are directed in the most meaningful way to abate the crisis that that Maine has been struggling with, the opioid crisis, for quite some time. So really, please take that as supportive for the effort that Representative Warren has presented to the committee today. My testimony, I'm not going to read it. I'm just going to hit the highlights. I think where I can be of some value is providing information about the status of this litigation and these negotiations across the United States. We've been litigating, investigating, negotiating on a number of different fronts and are at a number of different points with distributors, manufacturers, and retail pharmacies, all in different stages to get relief that is due for the contribution that these different entities made to the opioid crisis across the nation, but certainly here in Maine. In addition, not only is the state of Maine engaged in these efforts, it's also been referenced today that there are some political subdivisions who have also sued separately that here in Maine that we're trying to keep track of and trying to figure out how we're going to be coordinated with. And we just received word recently that perhaps some school districts in Maine are also going to be engaging in litigation. So we're trying to keep track of that to ensure that whatever dollars do come into the state of Maine, to whomever they go to as part of this litigation, is directed in the most meaningful, accountable way to address the crisis that we have. The suggestion, I guess, that we had, although I don't know how strong this needs to be, in one of the sections, section 3 of the bill, subsection 4, it talked about a recognized pathway. We were sort of thinking evidence-based pathway may be more appropriate, but again, that's really, I want to be deferential to the legislature here about how it best thinks that these monies may be targeted. Additionally, the only thing I guess I want to make sure we're thinking about is these negotiations so far have really only identified modest receipts of funds to the state of Maine over the term of about 18 years. That seems to be sort of consistent discussion about what we'd be looking at. So I highlight that because it is going to be so important that what the legislature does in directing these funds be done in a way to make sure that we get the best use of those resources within the time frame that we have them coming in. My office is available to answer any questions. Senator Claxton, I heard you ask a question of Professor Tate that we may be able to provide some help on, certainly for purposes of members' questions or the work session. I have 2 attorneys who this is pretty much their only job to be litigating these cases. I can make sure that they're available to talk about what we can talk about in terms of how we're doing what we can to get the resources to plug into something like this, because the legislature really is in the best position to determine how to best direct these funds.
Thank you for that testimony, Mr. Attorney General. Representative Madigan.
Thank you, Mr. Chair. Thank you for being here, Mr. Attorney General. I have a question. Does your office foresee this as being something akin to like the tobacco settlement money where, we have a fund and someone in your office is involved in keeping track of that money in some way or how it's used to make sure that it fits with that? If you could speak to that.
Thank you. So this would be, and I think we heard Ms. Shaughnessy talk about this a little bit earlier too. The idea is that there are some guardrails that established, like the tobacco, the Fund for Healthy Maine, right? Where there is a framework that is set up to legislatively direct where these funds go, setting up some level of protection for this resource so that it's going to the place where it needs to go. I think maybe the difference that I think is could be valuable, at least I put out that it could be valuable. So of course, my office, we're not going to be good at the directing the resource, right? We can get it, but other people who do this day in and day out are going to be in a better position to direct where the resources should go. But having the Attorney General in the position to advocate that this money be protected and have a figure that is there saying, no, hold on. We litigated this. We have a commission. It's been set up. Let them do their work. Don't take their money. That's going to be something that maybe we don't see as clearly with the Fund for Healthy Maine that might be helpful in ensuring that these resources are protected to be directed in the consistent with the litigation. So that's kind of a long answer to your question, but I hope it demonstrates that there are this framework is consistent with what we saw with the tobacco settlement, but it also ensures that there's somebody who is going to be in a position to advocate that those funds only be used for the purposes for which they were obtained and for what the commission is set up to do.
Thank you. And one follow-up. So you're making a suggestion how we could do it better this time.
Well, I'm highlighting that the sponsor building this bill did a good job at making sure that there was somebody, a person who people recognize when they come forward and say, no, don't take this. This is working well, advocating for making sure that those dollars are protected. So I don't want to take credit for that, though. I do want to suggest could be an improvement over how the tobacco funds were directed.
Thank you, Attorney General Fry.
It strikes me that we'll be hearing a bill in the next session about establishing a trust for the Fund for Healthy Maine. And it occurs to me that maybe the models should be more similar than disparate in that work. So yeah, it's interesting idea. The only other comment I'd make would be, in the interest of a friendly amendment, would be that best or evidence-based in the medical literature has largely been replaced by best evidence, because the evidence changes. And what would have been evidence-based at one point now may be not evidence-based. So I'll at some point we'll ask the sponsor if she would accept that as a friendly amendment. To build on your suggestion, Attorney Fry. Any other questions or comments related to this testimony? Thank you for being here.
Thank you.
Thank you for your contributions. So in the absence of other folks who'd like to testify, I'm not seeing any hands up. That'll close our consideration of LD 1722. Are there questions of, looks like Aaron won this bill. Are there questions that we'd like to direct to Aaron in anticipation of the work session? Representative Meyer.
Thank you, Mr. Chair. I would echo the request you made for what other states are doing, if anything, right now with these funds, what they've got set up, what they're considering, if that's possible.
Okay, and we all have access to the bill that we'll be considering in the next session, the LD for which I've lost, but it's the Trust for Healthy Maine funds. So that might be a good thing to read over before we sit down to work the bill. See if there's some other ideas in there we want to include. I don't see any other questions or requests of Aaron. So that'll conclude the formal consideration part for LD 1722. Is there anything that you want to do right now, Aaron or Anna, before we break for a caucus?
Thank you all.
Thank you, Representative Warren, for bringing this forward. Okay, so we've been joined by Representative Javner just in time for a break. Welcome, Representative Javner. Would you care to introduce yourself and include all the towns that you represent, please?
Good morning, everyone. I'm Representative Kathy Jabner. I represent House District 141, which is located in Penobscot in Washington County.
My legislative week is not complete, but we'll soldier on. Good to see you here. All right. So at this point, I'd ask the committee's indulgence for a 15-minute caucus break, reconvening at 11 o'clock, and with the intent to at least do a work session on LD 296, and with the possibility of doing a work session on LD 1718. But we'll hear back from the caucuses. So we'll be back at 11 o'clock. Okay, we can reconvene the Health and Human Services Committee meeting and transition to a work session on LD 296. We appreciate the sponsors bearing with us as we shuffled the work session for this thing, and glad that you can join us, Representative Cloutier. All right. So since this is your bill, Anna, do you want to start?
Sure. Okay. Just need to get my down arrow here. All right. Oh, I'm at the beginning, not at the beginning. Sorry. All right. So this is an act to provide a tax credit for family caregivers. And I'm just going to go straight to the amendment version. And I'm going to concentrate on the resolved version, since that seems to be the one that I have heard people have the most interest in. So this would require DHHS to establish a family caregiver grant pilot program in cooperation with the area agencies on aging to expand the use of the respite care fund established in Title 22, Section 7308, which is at the bottom of my thing, to increase the number of families served, provide a family caregiver grant, and examine needs and preferences of families served by the respite fund. The pilot provides a grant that is no more than $2,000 a year to family caregivers, or actually total, to family caregivers not otherwise being paid for caregiving or receiving services under 7308. The eligibility is adult family members or other informal caregivers 18 plus years caring for individuals 60 plus years, or to any age individual with Alzheimer's or related disorders, older relatives other than parents caring for a child less than 18 years old, younger than 18 years old, and older relatives, including parents aged 55 years caring for an adult 18 to 59 years with disability. And I can show you where that comes from in a moment. It requires a stakeholder group to make recommendations for development of the program, implementing the program, and evaluating its impact. And beginning October 2022, expenditures up to $5 million on a calendar year with up to 10% of administration costs. The pilot enrolls participants from October 2022 to September 2024, so 2 years, and it requires a report to this committee in January 2025. There are some drafting issues. I'm a little confused about the use of the respite care fund being expanded. I think it's serving more people, but I want some clarification on that. But I don't, expanded suggests to me different kinds of services, but I'm not sure that that is the case. But I'm sure that there are other people who know this much better than I do. I just want to make sure that that's correct, that's all. The stakeholder group is slightly unclear. The group must be convened by October 2021, and the bill does have an emergency preamble. I should have mentioned that. And the language includes development of the program, but then it says the department may convene a group to assist in designing the pilot. And it's not entirely clear to me whether those are different, development versus designing. They seem sort of the same, so it's not clear to me whether the stakeholder group is going to be involved in the development of the program or not. If the funding doesn't begin until October 2022 and the group is not assisting in designing the plot, then it's not clear to me, pilot, it's not clear to me what its duties early on are. So if they are designing the pilot, that just needs to be clarified. It's also unclear how often the group has to meet, and maybe that's okay. I just wanted to point that out. Eligibility is determined in terms of caregivers and those who are cared for. And then the resolve also cites that the data should include wait lists. So I don't know how the individuals to receive the grants are chosen. I assume that the department would determine that in rules. I just think that that rules language needs to be a little bit clarified if that is indeed the case, because the grant program has finite funding, but it's unclear how eligible persons are chosen to receive the grant. So it sort of reads a little bit like an entitlement program, and I don't think that it is intended to be if there are wait lists. And then just the last thing, the program begins in October, but the fund is based on a calendar year, 5 million of calendar year. It might be easier if it's a 2-year project just to have 5 million in each of those 2 years rather than basing it on a calendar year. There was some additional information. Probably should have crossed out the requested by committee because it was me that requested this information. So I didn't know how much the Respite Care Fund gets now and what its funding source is, and whether it's all spent every year, and whether there are any restrictions on that fund that conflict with 296. So we got this answer from ODES that there is no specific legislative allocations to the Respite Care Fund established in the law, but each year there is $566,057 of state general fund as part of the ODES annual budget that is used to support the state-funded Respite Care program through contracts with the area agencies on aging. And the area agencies on aging are allowed to use the 10% of that for administrative costs. So I think that's where that 10% language comes from. It's entirely consistent. And the area agencies do expend all of that money. There are no restrictions on the use of the funds because they are state general funds. However, any amount of these funds used on a pilot grant program established in this bill will lessen the amount available to spend on the regular state-funded Respite Care program. The bill states that the caregiver may choose annually to receive either services provided under 7308 or the family caregiver grant established in this bill. And the ODES understanding is that any newly allocated funds for the pilot will also be available to support the state-funded Respite Care program. And then there was a lot of testimony during the public hearing that referred to federal funds and whether that might be an option. And ODES responded that they are not aware of any ARPA funding that is targeted to this type of program. If the thought is that some of the 10% home community-based services FMAP increase could go to this purpose, they don't believe CMS would approve such a use, as those, because they're FMAP funds, must be spent on Medicaid eligible individuals. And this current respite program and the expansion envisioned in this bill would serve a much broader program. And this is just the existing program down here. So I just wanted to show you something else while I have the only problem is I don't know which screen it was. Okay, hang on a minute. I just have to find where it is. So let me, sorry, try that again. Now, hopefully you can see this. This is the National Family Caregiver Support Program. I just bring this up because this is what's under 7308. And so you can see here the purposes of the program is currently information, assistance, counseling, respite care, and some supplemental services. And I just wanted to show you this also. This is the 4 groups that are in that bill, in the result, I should say. And I just wanted to show you that because I wanted to see what expanding services meant, and I didn't know if it was the groups of people, and it clearly is not. So I just wanted to show you that. This is on the ACL, which is a federal agency's website.
Thank you. So what kinds of questions does that raise for anybody? Representative Perry.
I guess my question is, are we really expanding services or enhancing them?
Or just more people was my question.
You're broadening the eligible, by increasing the amount of money, you're increasing by almost a factor of 10 the number of people who can participate. Do I have that right, Representative Cloutier?
Thank you, Mr. Chair. So it expands upon, well, 2 things. So it expands upon the fund in the sense that it adds the grant as an option to the reimbursement. So there's that sort of expansion. And then by opening it up in that way, it expands the number of people that would be served. So I think the answer to Anna's first question on that bullet list is yes to both of those things, if that makes sense. So I'm actually wondering if it would be helpful for folks if we brought Anna's list of bullet points back up, and then I can answer the questions that she had.
So you're not, so while we do that, you're not expanding services, you're expanding availability.
Right. Yes.
Okay.
Yes.
All right. I think that was the expansion she was asking about. Are we offering more people more things, or are we just offering this to more people?
More people. Right. More people.
Yeah. Okay, good. All right. So that's the first bullet point. Do you want to go from there?
Sure.
Stakeholder group.
Yeah, so the stakeholder group. So the stakeholder group would be responsible for doing the development. So I think that was the first question there. And the version I have identifies, instead of saying may, it says shall. So I'm not sure if that got changed from the first version to the resolve. But I think we were looking for the shall convene as opposed to the may convene. And the designing and development are the same. And so I think that also answers the question in terms of what are the duties early on. It will be to develop the program.
So do we think we would need additional funding to get this up and running by October 2022? Because the funding doesn't begin until 2022. So we can't access the 10%.
So so in terms of the funding, so the way that we were thinking about it, and I got together with stakeholders this morning, so we're talking about 3 years. We're talking about 22, 23, 24. And I think we would need approximately $200,000 in that first year. One, because I think the folks in ODES would like somebody to oversee the program. And in that first year, if we don't have that 5 million and that 10% cap, there wouldn't be any money there to fund that. And then we're also looking to, when we're talking about the evaluation, bringing in a third-party organization to do that evaluation. So it's not the department doing its own evaluation. And I think we need to engage those folks early on in the process so that they're doing the data collection and helping us think about the development of the program and putting together the assessment modules prior to when they're actually having to do the evaluation. And so I think that the costs of those evaluations are typically $80,000 to $100,000. And so I think if we set aside $100,000 for that and $100,000 for somebody in ODES to manage the program in the first year, that's $200,000, and then move to the $5 million appropriation for the additional 2 years for the pilot. And then I also think that increasing that 10% administrative cost to 15% administrative costs makes good sense. When we envisioned this program as a tax credit, we had set aside $500,000 for the AAAs who will be actually doing the administration of the program, who are currently doing the administration for the Respite Care Fund. And there are 5 of those across the state. And so we had allocated $100,000 for each of those AAAs to do the administrative work for the program, but also hadn't built in that $100,000 for the person in ODES going forward for each of those years to manage it. And so I think if we increase that to 15%, that covers the AAAs and the ODES person.
Okay.
And then in terms of how long the stakeholder group is required, I think that they and the department should probably determine that and how often they're meeting to figure out the design of the program. So obviously, if they start meeting in October of 2021, which is when we said the stakeholder group needed to be convened, and the program started in October of 2022, they know how much time they have, they know what they have to do for a scope of work, and they can figure out sort of how many times they need to meet within that time frame to get that scope of work accomplished. And then just going back to the first bullet point for a second. So the Respite Care Fund, I think, as Anna showed in the other screen that she brought up earlier with the Family Caregiver Support Program, the federal program. So the Respite Care Fund oversees the Family Caregiver Support Program. And that program, I think, covers more the Family Caregiver Support Program, and ODES, I think, can speak more knowledgeable. I know that ODES can speak more knowledgeably about this than I can. but there are differences, I think, between the two in terms of who it covers. And so I am comfortable with going with who the Federal Caregiver Support Program covers. And that's the language that is in the resolve that you saw. But I think that who is covered under the current respite care program is a little bit more limited, and it's limited, I think, to the dementia population. And so I think we want to be more expansive than the respite care fund, and want to fit it within the National Family Caregiver Support Program. Does that make sense to you, Anna?
Yes, it does.
Okay.
I didn't know enough about how the state program worked, but that makes sense to me.
And again, I think that the folks from ODES can provide more clarity around that. And then the third bullet point, I think Jess Maurer from the Area Agencies on Aging might be here. And I think that she can speak more definitively to that. Currently, as I mentioned, the AAAs across the state are doing the administration of the Respite Care Fund, and we would want that to continue, and they are agreeable to doing that for this pilot program. But Jess, I think, can clarify how they make those determinations and sort of what the eligibility requirements are. And again, I think the ODES folks could also provide clarity around that.
But those already exist. So we're not talking about having to have a new rules. No. So these are already rules that okay, good.
Yeah, these are, so we are basing this program pretty solidly on what is already presented in the Respite Care Fund and the Family Caregiver Support Program, rather than trying to create a whole new thing. It really is just adding in the opportunity for folks to get a grant, and then taking a look to see who utilized the grants versus the reimbursement program that already exists.
And both Molly and Jess Maurer are in the room. So we can check that out with them when we stop here.
Okay.
And then the other one was the funding cycle. Any comments about that?
Yeah, so the October date was one that was proposed by ODES because it keeps them in line with their reporting structure for the Federal Family Caregiver Support Program. So it was trying to keep everything on the same schedule so that they weren't having to do reporting at different points in the year. So again, I think maybe the ODES folks could speak a little bit better to why that was the selected cycle. I'm completely open to whatever works. And then the other thing I just wanted to, Anna, if you could scroll down. Thank you. So the way that we're thinking, so currently there's money in the Respite Care Fund, that $566,000. I want to be clear that there's no intention for us to use any of that $566,000 on the grant program. However, if this gets voted out of committee favorably and it goes to the appropriations table and we are lucky enough to get it funded, some of what is in the pilot program could also be used to cover reimbursements through the Respite Care Fund. So I want to make sure that it's clear there's that reciprocity, that folks would have the ability to choose whether they wanted to get a reimbursement or whether they wanted the grant program from that $5 million allocation. And then in terms of the ARPA funds, I made reference to that in my testimony. I in no way meant to imply that there was that there were restricted funds for this kind of, to fund this kind of programming. What I was trying to say was that, and clearly I didn't do a very good job of it, was that there are federal unrestricted funds. And when we had originally envisioned this program as a tax credit, because ARPA funds don't allow the use to reduce taxes, it was unclear whether a tax credit would be eligible for the unrestricted ARPA funds. By moving this over to a grant program, we've opened up we've opened up the possibility of not only, again, if this is voted favorably out of committee and lands on the appropriations table and is eligible for funding, that it's not only eligible for general fund funds, but it may also be eligible for federal ARPA unrestricted funds. I was in no way suggesting that we should use FMAP funding for this or any restricted Health and Human Services federal funds. So I hope that was clear. I'm happy to take any other questions or defer them to people more knowledgeable than I am.
Are we doing okay on the bullet points, Anna, so far? Good. Okay. So we had referenced that Jess Maurer might be able to fill in some blanks for us here. Is that something you'd like to speak to, Jess?
I certainly can try. Absolutely. So I'm Jess Maurer. I'm the Executive Director of the Maine Council on Aging. And if you've got specific questions, I'm happy to answer them. But I think the idea was to help you all understand. So that currently the AAAs administer two different programs. So that is the National Family Caregiver Program and the Respite Care Program. And I think as Representative Cloutier mentioned, the language in the bill says that it expands the uses of the respite care funds. And that's the idea. So currently the Respite Care Fund itself, which is in state law, is only available to assist people with Alzheimer's and dementia. And so that fund, that $3,800 that people can get annually to pay for respite is only for folks who are caregiving for people who have Alzheimer's and dementia. Whereas as you saw, the expanded group under the National Family Caregiver Act allows them to provide other kinds of support. So they provide information, they provide support groups, they provide training, evidence-based training, options counseling, other sorts of direct support and information to family caregivers who are not caring for people with dementia. And then this fund is very specifically for people with dementia. And so when it says it expands the uses of, it means now you can use those funds for people other than people who are caring for people with that Alzheimer's. And the way this works currently when you're operating under the respite fund is that there's actually a person who creates a plan of care for that family for that respite money. And so if somebody needs, for instance, 3 hours of respite a week to go to or a month even, to go to the grocery store and get their car fixed and pay their bills and that sort of thing, then that person the person that works for the area agencies on aging creates the plan, helps find the provider, pays the provider. So that's the way that program works, which would be then we're saying we're going to develop a similar kind of program for this grant money that would probably do a very similar thing, right? Would work with the family to understand what the uses, what the needs of that grant money was, and how they wanted to receive those funds, whether they wanted the AAAs to pay those funds directly for them and negotiate a care, a provider to help them, or whether they wanted to receive that as a grant and administer that themselves. So I think that's the gist behind this. And that's what the work group would be figuring out, is how exactly that would be administered, including eligibility.
For which there's already some working tools.
That's right. You have to, in order to be eligible for the respite program, you have to have a doctor's, a physician's a diagnosis of Alzheimer's and dementia. You have to have a certain level of liquid assets. You have to not be eligible to receive any other assistance from any other subsidized program, and the care recipient must be 18 years or older.
So we can build off of those. Okay.
Yep, exactly.
In the rulemaking. Yeah.
Exactly. Those already exist.
All right. Molly, did you have something that you wanted to chip in here?
I think Representative Cloutier and Jess have covered it well. I mean, I don't want to get too caught up in the respite program. That's really the it's the structure that provides us with the roadmap for how we're going to achieve this, but this really is a separate pilot. And so that, if that is helpful at all, that's, I think important to recognize.
So are we clear about those various bullet points and ideas? Anna, do you have enough sense of the intent?
I guess I'm still actually, I might be more confused than I was before, truthfully. I think it's really the point that Molly just made about this being a separate program, but it's not written that way. I mean, it's written kind of referring to it, saying you can get services under either, and maybe that's all okay. I'm just saying that's why I'm confused. The reason I asked the expanded question is because there's already a section in law that, although it's not very prescriptive, which is helpful, and I wanted to make sure that this didn't conflict with something that was in law. That was given that this is a resolve. That's why I asked the question. But I think given that section 7308 isn't very prescriptive, then I think maybe that's not an issue. And my question about eligibility and rulemaking wasn't about who's eligible, it's about who's chosen, like who actually participates. And I just think that language needs to be clarified, but I think I can figure that out. It sounds like if, by working with the department and with Jess, that can be clarified. It's not, I'm just saying it's that the language wasn't that clear, and that was what prompted that particular question as well. Because there's obviously, I mean, when you refer to wait list in the report, that suggests not everyone can be served.
You're talking about eligibility and selection.
Yeah, I'm talking about participation. Yeah.
Yeah.
And that was the part that I was asking about. I didn't know about who could participate in the respite care program, and I'm glad to know that it's limited to Alzheimer's. I mean, I'm talking around in circles now. I still think there's some clarification that needs to be in the language, but I think between all of the participants, I can figure most of that out.
Molly?
I am probably taking some liberty here, but since I saw both Jess and Representative Cloutier nod pretty emphatically when I was speaking, I'm going to expand just a little bit and say, one of the great things about this is, I just want to share our appreciation for how much Representative Cloutier has really taken our feedback on how to structure this. And I think the bill has gone through a couple of drafts, and one of them included putting it in that section of statute. And so I think some of the confusion may just be remnants of that draft, but I think, having it be separate seems to be the plan. And part of the reason it's in unallocated, we've drafted it as the resolve in unallocated language, and that allows it to truly be a pilot that we can assess and, make sure that all the pieces work the way that they're intended before perhaps proposing to have it ongoing in statute. And I think for the who is chosen among those who are eligible, it feels like that could be a conversation with that stakeholder group. And that's obviously going to have heavy involvement from the AAAs and done through the rulemaking that we'll have to do. And so as long as the committee is comfortable with that, I think that would be what we would recommend.
So yes, Representative Craven.
Thank you, Mr. Chair. I would like to make a motion, and the motion would be ought to pass as amended.
Representative Perry? That was the second? Yeah. So there's.
I'd also authorize Anna to work with Representative Cloutier and also Jess Maurer for the word and the department.
Can I ask another question about the issue that Representative Cloutier brought up about the position and the evaluation and the $5 million in each year? It may be that needs to be spelled out. I think that it would make more sense to have, if there's a position involved here, that's a lot easier for Luke to put in as a position. And also, I think the evaluation is something that would probably be spelled out as its own thing. But it does, I still have the question, and I'm kind of going to look right at Molly for this one. The 5 million for the actual program and grants, that is 5 million from October to September and October to September, correct? Yeah, it's not really a calendar year. I understand what Representative Cloutier is saying about how they need money before and after, but if you're spelling that out for a position and an evaluation, then they won't fall into that October to September thing. Right, Molly? Does that make sense to you, what I just said?
It does. I think, yeah.
And obviously we can continue to work on that, but I just wanted to make sure that I think that the 5 million is not in a calendar year, but October to September and October to September. Okay. And I get the federal part of that. That makes sense to me too.
And there's still, as I heard it, an initial allocation of 200,000.
Well,
Go
I
ahead.
heard it was separate from what Representative Cloutier said. Half of it was for a position and
Yes.
half of it was for, yeah.
Yep. Half for position and half for evaluation development from an academic or not-for-profit resource. Okay. And we talked about 15% on the administrative costs. And those are the other amended portions that I recollect. What else is missing, Anna?
It's more wordsmithing, including clarifying all the stakeholder group. I was still looking at a may, Representative Cloutier. But I think that if it's a shall, it's actually easier to draft that slightly differently. It doesn't need to be separate. It can be all one paragraph is what I see there.
Yeah, it should be shall.
And your motion, Representative Craven, was ought to pass as amended.
Yes.
Thank you very much. All right. Are there any residual questions? All right. Carrie, why don't you go ahead and tally the vote?
Representative Zager. Representative Zager is absent. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
Yes.
Representative Stover, yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer, yes. Senator Claxton.
Yes.
Senator Claxton, yes. That's 11 yes, 2 absent.
Thank you for that. And thank you for a productive conversation about a program I hope helps a lot of families. So thank you, Representative Cloutier.
Thank you all so very much. I really appreciate it. Thank you.
Your work effort on this is impressive. So well done. All right. So having concluded the work session on LD 296, I propose we go into a work session on LD 1718, which is the Accidental Drug Overdose Death Review Panel. This is the bill that was passed unanimously in the last session in its amended form. Senator Moore.
Yes, in view of this, I would actually make the motion of ought to pass on LD 1718.
I would second that.
Motion has been moved and seconded for LD 1718. Is there any additional conversation about this bill?
I'm just going to remind you about the public records exception. That's all, just so
Yes. So
you remember it's there. That means the chair will have to pop along to judiciary at, I believe, 1 o'clock on Wednesday.
I understand we have a tentative appointment, so if you could firm that up. And I will be there at 1 o'clock on Wednesday. Yeah. Okay. All right. So Ms. Withy, why don't you do the vote on ought to pass for LD 1718?
Representative Zager. Representative Zager is absent. Representative Lumlin.
Yes.
Representative Lumlin. Yes. Representative Stover.
Yes.
Representative Stover. Yes. Senator Baldacci. Senator Baldacci is absent. Representative Perry. Representative Perry is absent. Representative Griffin.
Yes.
Representative Griffin. Yes. Representative Connor.
Yes.
Representative Connor. Yes. Representative Craven.
Yes.
Representative Craven. Yes. Representative Madigan.
Yes.
Representative Madigan. Yes. Representative Javner.
Yes.
Representative Javner. Yes. Senator Moore.
Yes.
Yes.
Senator Moore. Yes. Representative Meyer.
Yes.
Representative Meyer. Yes. Senator Claxton.
Yes.
Senator Claxton. Yes. I see Representative Perry has joined us. Representative Perry, the motion is ought to pass on LD 1718.
Yes,
Yes, thank you.
my computer died, unfortunately.
That's 11 yes, 2 absent.
Okay. So at this point, we're getting close to finishing up. We've talked with the leads and analysts about a short meeting afterwards to go over the remaining bills and their status, so we can do some planning for the committee. We have a work session on Monday and Tuesday related to the budget. And Carrie, do you have your hand up?
Yes, thank you, Senator Claxton. If everyone could just check their inboxes today for an email from Casey Milligan in the Legislative Information Office. If you haven't replied yet, if you could reply today, that would be great. Thank you.
Thank you for that reminder. Anna.
Okay, this is not ideal, but I'm getting this off my desk, so I'm doing it anyway, and I shall check in with him later. So I have 2 amendment reviews here, but they are 12-1 reports for Senator Baldacci, who is not here. But I'm going to show them to you, and then I'm going to check in with him later so that I can pop them off my desk. So okay. So I'm just going to quickly show them to you because I don't want you to be unaware of what they are. There are 2 of them. This one is the Housing Navigator position. And you can see there, this is the cost of the position. And the second page, this is what will go on to the bill, or rather go on to the amendment for Senator Baldacci. The remainder of the committee was ought not to pass. Did that just change to 1263? Can you see that? Did that work?
It did.
Okay, good. So this is literally, I kid you not, the longest fiscal note that I have ever seen that is not a budget fiscal note. So this is another 12-1 report, ONTP, with Senator Baldacci voting in favor with a fiscal note only. This is the Senator Diamond's bill to create a separate Department of Child and Family Services. You can see here, this is the cost of that. And I'm just going to show you the beginning. Well, actually, you can sort of see it on here, that there are 11 new positions. I'm going to go on down just a little bit. I will not show you all 16 pages of it. These are the new positions right here. This generates the cost. And then when the next few pages, I'm just going to show you a couple of them. This is transferring positions from one place to another. So you can see over here, there's a cost on the right-hand side. And then if you go down multiple pages, got to go further. You can see the negative side, and that's because you're moving them from one place to another. But there is a cost to that. But I just wanted to make sure that you were all aware that that was out there. I did send it to you by email, and they'll get posted on the web. And I will touch base with Senator Baldacci, but those ones were done mostly because I'm drafting amendments, but Luke's actually doing his fiscal notes. So if there was no amendment needed except a fiscal note, that's why that one what I'm trying to say is that I try to prioritize some of the divided reports or unanimous reports rather than the 12-1 reports, but these were fiscal notes only, and so they were ready to go. And that is all I wanted to share with you before you left today.
Anything we can get off of your desk and our desk is a good thing. So,
and Luke's desk.
And Luke's desk, 16 pages. There should be some chocolate in there somewhere. All right. I would ask the chairs and leads and analysts to join us on the chairs, leads, and analysts link. And hope everybody has a good weekend and enjoys some sun. So Senator Moore, you're headed back at some point. Can we do you want to get it? Do you want to get it on the road first or? Okay. All right. Good.
I'm fine. I'll stay here. Yeah.
Okay.